Sadly, I have no financial disclosures. I'm not getting paid for this. I do want to thank Greg Schrock for a couple of the slides that I'm using. So I think historically and certainly probably 10 years ago, pain became the fifth vital sign. And so the goal of many people was to stamp out pain. And so the problems that occurred from that, so historical treatment is, again, you have a little bit of pain, we give you some opioids, more pain, more opioids, and you have severe pain, then we give you a lot. I think what we need to think about now with multimodal analgesia is understanding that we want to make patients comfortable, but pain-free is not always the goal. So there's a little bit of change in the way we're treating pain. Again, analgesia, we use several different medicines, analgesics, anesthesia techniques, and then finally opioids to help treat pain. And these medications work through different receptor sites and by different mechanisms. So the result is you get either an additive or a synergistic effect when you combine the medications. So treating pain, the fifth vital sign, resulted in problem, the opioid epidemic. So in 2015, the CDC had this slide available that said 78 people die every day of overdosing on painkillers. That number is closer to 100 now, so in just 2 years. This is a kind of a busy slide, but it's a real problem. $65 billion costs every year. There's emergency departments that are full of people needing pain treated or looking for medications. And inside was amazing to me. On an average day, 650,000 opioid prescriptions are dispensed. So a lot of medications out there. And probably each of us, if we thought about it, might have some of these at home in a medicine cabinet or a closet somewhere. So just be careful. Drug overdose is the leading cause of accidental death in the United States. There are more than 64,000 lethal drug overdoses in 2016. The leading cause of death in those under 50 years of age, which is most of us. Come on, just a number, just a number. But at the bottom of the slide, I did put the comparison deaths. So you can see that drug overdose is a bigger problem than we think. He has this graph, again, it goes up to 2014. The numbers are going up, both men and women. So this is not a gender-specific problem. This is everybody problem. And at times we think about drug overdoses as being street drugs, heroin, some of those kind of things. The reality is the synthetic opioids are what's increasing use and increasing problems. Again, from the CDC, looking at the number of prescriptions by county. And so the darker colors have more prescriptions per person. State of Michigan, and I can see where Kalamazoo is, right there. So Michigan does have a problem with prescribing, and if there are more medications available, then you're going to have a bigger problem with overdose. This slide, because again, many of us have children or did have children in the large public Midwestern Research University. I don't know what that is, but the results of this study said that prescription drug abuse is a problem among college students. So in 2006, this was the number of men and women who were taking prescribed medications while at college. So you can see our number of students who are taking those same medications without a prescription. So prescription drug use is a problem. Prescription drug overdose is also a problem. sort of decrease a little bit some of the medications that are out there in the community. So again, historically, this is really older than most of us in here. Medications were available to soothe children, but again, the ingredients showed that morphine and alcohol were the major ingredients. With the historical approach, again, getting a little bit of opioids for mild pain, more opioids as your pain gets worse. Opioids do have a ceiling effect, so if you give more and more, you don't get increasing treatment pain. They do have significant side effects. You develop what's called hyperalgesia, and I'll talk about that in a minute. And then, of course, there's significant addiction potential. So is where you get a paradoxical response where a patient, in fact, becomes more sensitive to their pain when you treat them with opioids. And so this is, in the operating room, known some of the very short-acting but potent narcotics are more likely to cause this problem. But again, it sensitizes the patient to painful stimulus. The thing we have to be aware of is what's called allodynia, where what should be non-painful stimulus causes pain. So even just touch, movement of clothing over an arm can be sensed by the patient as pain. So those are things I'll talk about a little bit later. So ceiling effect of narcotics. So or the opioids. Once you get more than about 100 milligrams of what are called morphine equivalents, add more opioid isn't going to help the patient. But the higher amounts do lead to increased risk of overdosing. So if you're between 50 and 100, you have a fourfold risk of accidental overdose. If you, again, have more than 100 milliequivalents, morphine equivalents per day, then you have almost a tenfold risk of overdosing. But these are the common drugs that we use around the time of surgery. Morphine is in the big box here, and it compares the doses. So 10 milligrams of morphine is equal to 20 milligrams of Percocet. So these add up. We all have seen patients who come in and they're taking many doses of 10 milligram Percocets. And so there is a ceiling effect, but they're also at risk for having drug effects we all know well. Non-constipation, almost everybody gets constipated, itchiness, dizziness. The big information on this slide is at the top that most post-surgical patients would choose to have less pain relief if they could doubt the side effects. So they may then be nauseated. That's the one that we see most commonly. There are some risk factors for patients who develop chronic opioid use after surgery. So this study from 2016 basically said there are several patient factors. So male gender, age than 50, so it's the older folks, benzodiazepine, alcohol or drug use pre-op, and then if you have some mood disorders like depression or anxiety. But there's also some surgeries that are associated with increased risk of chronic opioid use. And these surgeries, as you know, we do every day. So total knee replacement, simple mastectomies. You know, when you look, there's the 5 highest risk ones. Even laparoscopic cholecystectomy is on that list. Total knee arthroplasty, a very painful procedure. Many patients are on chronic opioids 6 and 9 and 12 months after surgery. So from this past year, out of the University of Michigan, it was a population-based study looking at adults. 36,000 surgical patients showed that their new persistent opioid use, which means they're still taking their pain medications at 90 days or 180 days, was 6 to 6.5%. So a problem. There's no difference whether they had a minor procedure or major surgery, but it's the same risk factors. Tobacco, alcohol, or other substance abuse disorders, anxiety, depression, and those who have chronic pain problems. Opioids have been around for a long time, but they have these problems with their use. A lot of side effects. Chronic abuse is a problem. If we more and more, it doesn't make the patient feel any better, and they can develop hyperalgesia. So what we need to do is talk about multimodal analgesia and how we introduce that and use it more commonly in our patients. So American Pain Society came out in 2016 with some guidelines, making it clear that we have to educate our patients better, especially about expectations related to their surgery, so that the expectation should not be that they're pain-free, but they're, that we get them comfortable and able to do the things they need to do. We have to use validated pain assessments, multimodal analgesia, which again I will talk more about. And then in the operating room, I have to use more local infiltration and regional or neuroaxial anesthesia. These are preferred over IV medications. And again, we have to monitor for adverse events. And then we have to give the patients and their families some guidance as to how to get off the medications. We can't keep refilling their prescription for pain medicines and expect patients to get off their own opioids. Anesthesiology, again, said whenever possible, multimodal analgesia, we should use some of these non-opioid treatments. But at a minimum, something we don't do is schedule acetaminophen and non-steroidals. Everybody's used to this PRN, like 1 or 2 Norco every 4 to 6 hours. The reality is we should be taking acetaminophen every 6 hours, interspersing that with a non-steroidal, and adding opioids on top of that. So combination drugs can cause a little bit of the problem we see today, and I'll talk a little bit. And the American Nursing, the American Society of Pain Management has nurse guidelines also that says the nurses have to act as strong advocates. You have to know about the pain medicines that the patients are going home with. Then you have to be aware of the distinction between the different pain medications that your patients are getting. So it's not just the opioids, it's what adding on to that. What happens if you add a benzodiazepine? What happens if you add a sleeping pill? And you have to know about some of those medications. Science, 3 major types of pain. Nociceptive pain is what happens when you injure tissue. So if it's somatic pain, that's like if you get a cut, break a bone. Pain is well localized. You can point to exactly where it hurts. So that's different than visceral pain. Visceral pain is something from inside our abdomen usually, smooth pain, and then that's where you get referred pain. So that's why if you develop appendicitis, it starts around your umbilicus and then starts moving around your abdomen. So sometimes that referred pain can be more difficult in helping make diagnosis. We also see patients commonly who have neuropathic pain. This pain is usually in the somatosensory nervous system, and it's involved in pressure, temperature, positioning of different body parts. And those patients with numbness, they can have hyperalgesia where they have more pain than you would expect them to pain, or more pain to have, or allodynia, where just a simple touch can feel painful to them. So diabetic patients, post-herpetic neuropathy can present like this. Patients with spinal cord injuries can have neuropathic pain. And phenomenon is an example of this also. And there's also inflammatory pain. So if you have surgery, you have all these inflammatory mediators that are released as part of the surgical process, and those mediators can cause pain or worsening of pain for the patient. So multiple analgesia is what I'm here to talk about. For those of these medications, it is very easy just to give higher and higher doses of an opioid, but oftentimes that's not the right answer for our patients. So I'm going to talk about some of these kind of medications, acetaminophen or Tylenol, nonsteroidals, the NMDA receptor antagonists. So we use ketamine in the operating room, dextromethorphan as a co-medicine, talk about some of those, the anticonvulsants, local anesthetics, corticosteroids, and then I'll talk about some of the future therapies. So the anesthesia group does for the patients, and I won't go into all of these in any depth. We do have an increasing number of procedures we can offer patients around the time of surgery that can help numb up a portion of their body where they're having their surgery. So lots of places to put local anesthetic. The duration of those medications can last from hours to days. More about is some of the medications that are available to our patients. Is cyclooxygenase. It's mostly a COX-2 inhibitor, and I'll get into COX-2 receptor inhibition with the nonsteroidal medications. But it's felt to have weaker activity than the nonsteroidals, but it is effective. It's generally safe, has minimal side effects, multiple routes we can give it, IV, orally, or rectally. Absorption can be altered by other medications we give to the patients or by providing them with a general anesthetic, and then the rectal administration has variable absorption, so we just need to be aware of that. Currently, it's well to 4 grams a day, although there's some talk about decreasing the number to 3 as increasing amounts are seen in these patients. It's contraindicated in patients with hepatic impairment or heavy alcohol use, and it is felt to have more analgesic action than it was felt to have in the past. So a complicated slide at the left-hand side, it's the mean pain relief score. So the higher the number, the better the pain relief. And so the line is IV acetaminophen with a morphine PCA. The yellow line is a placebo plus morphine PCA. And what is important is that when you add this for total knee or total hip arthroplasty, that patients had got satisfaction or had better satisfaction, and the time to rescue opioid was longer, and morphine consumption was also lower. So we don't acetaminophen is a powerful drug, but the studies now show that it is a more powerful drug than what we had thought. This is IV acetaminophen, not oral acetaminophen. Use as much as people might think. So 500 milligram acetaminophen capsules cost 4 cents to the pharmacy, which is the IV acetaminophen is $32. So an individual patient, it's a low number. When you start adding this to tens of thousands of patients, it becomes money. There's another group of medications that we can use instead of opioids to treat pain. There's 2 receptors that the nonsteroidals work at. One is the COX-1 receptor that regulates the production of prostaglandins and thromboxane A2. And most of these effects occur in the GI tract, kidneys, and the vascular system. this COX-1 on the platelets, and so this is why people worry about bleeding with some of the nonsteroidals. COX-2 receptors are more involved in prostaglandins that are released during inflammation or pain. The nonsteroidals reduce inflammation, they decrease fever, they do have antithrombotic and analgesic effects, so they decrease blood clotting and provide pain relief. Again, these medications can be given by many different routes. So IM and oral. There are some transdermal medication or varieties of this medication available in Canada and in Europe. The COX-1 inhibitors, there's the concern for GI irritation or bleeding, worsening kidney function, and then platelet dysfunction. With the COX-2 inhibitors, about 10 years ago, 13 years ago now, we worried about cardiac and renal injury. So Vioxx, which is made by Merck, was an effective COX-2 inhibitor, treated pain well. Unfortunately, the patients developed cardiac side effects, including sudden death, and so Merck had to recall that drug in 2004. Those same problems have not been found by Celebrex. So again, Celebrex is a mostly COX-2 inhibitor, and it's been used in the interim 13 years with good effect. I've heard for a long time about the question of using nonsteroidals in bone fracture healing and lower rates of spinal fusion. That data is very questionable. It's certainly bad if you're a rat or a mouse, but it's not clear that these cause problems in humans. So I'll show a little bit of information about that. So one, as we give nonsteroidals, is what kind of COX-1 to COX-2 relationship they have. So the older nonsteroidals have about equal or more COX-1 activity than COX-2, and I put down the common ones that we're used to seeing there: Motrin, Toradol, Naproxen, and then acetaminophen. About equal or more COX-1 than COX-2. The newer selective COX-2 inhibitors, you can see Celebrex, 17 times more COX-2 effect than COX-1 effect. There's a medication, Arcadia, that's available in Europe, Japan, that earn 25 times more COX-2 effect. The FDA, it is in the process of trying to get FDA approval, and probably will have it available, but it could be a couple of years. They're generally safe, have minimal side effects, and especially with short-term use. So patients who take these every day for their arthritis, for example, we're talking about chronic use, and so they can have more problems. They are effective. Celebrex, 400 milligrams given in one study as a rescue on the surgery plus the next 3 days. Those patients had improved pain scores at 24 and 48 hours. They had faster return of bowel function, again, because fewer narcotics were given. And then they had the more rapid return to the usual activities. Again, a drug that's no longer available, but again, at the time, for the next 5 days, those patients had reduced pain and they had improved satisfaction and more activity after total knee replacement. Just a picture from that study, lower visual analog scale pain scores on post-op days 0, 1, 2, and 3. So again, effective medications. So about nonsteroidals and bone healing. So the first, I'll read this, but the reason I put that first paragraph up there is the literature data is inconclusive. There are studies that support it, and studies that support it, and other So very inconclusive when you look at the data, and the part of the problem is the majority of the studies, the doses that they gave were very high, and they gave them for long periods of time. So if you're using them for prescribed amounts and for a short period of time, they are good medications. They don't seem to change bone healing, and especially when you use the more selective COX-2 inhibitors like Celex, we shouldn't have any problems. Another drug that we use in the operating room and sometimes in the recovery room to help some of our patients is an NMDA inhibitor or NMDA receptor antagonist. And there are other ones that are available that we don't use, although there's been research on it. Dextromethorphan is commonly found in cough medicines. It also provides, there are some studies that show it provides pain relief in patients given orally. Magnesium, again, probably better given IV than oral, although there are patients with chronic pain syndromes who are given oral magnesium. Most commonly compared to PCP or angel dust. And we know that the analgesic doses, 10 to 3 milligrams, are much less than the anesthetic doses. So in the operating room, if we're using it as purely as an anesthetic, we're giving 1 to 2 milligrams per kilogram. So milligram dose versus analgesic dose of 10 to 30 milligrams. Reduces opioid tolerance in acute pain, certainly in spine surgery without increased side effects when you use the lower doses, and it does appear to have some anti-inflammatory effects. Again, I apologize, but the important thing is down below. This is a prospective randomized double-blind study that showed by using very low doses of ketamine, there was a 30% reduction in 24-hour morphine use, 30% reduction in 48-hour morphine use, and a 7% reduction in 6-week morphine use. So the ketamine is doing something with the pain receptors that is not only having an acute effect, but it's also having a more chronic effect and suitable to our patients. It's also been found out that ketamine does help with as an antidepressant, and so that some of the patients who are using opioid chronically after surgery, so there again, one of the risk factors was depression. So the use of ketamine, low dose, can at least for a short period of time act as an antidepressant. So this study out of 2014, there's a rapid-acting antidepressant effect for patients with diagnosed depression, but as we know, there's many of our patients have undiagnosed depression that we might be able to help them with, at least in the short term. The Pentanoids, another class of medications used to help treat pain. Gabapentin and pregabalin are the ones we know about. They're analogs of the GABA receptor and help decrease the release of excitatory neurotransmitters. So the problem, gabapentin's been around probably for 40 years. It was initially an anticonvulsant. The problem compared to pregabalin is that it's only absorbed in a short section of the duodenum, so there can be a ceiling effect. So bigger and bigger doses may not provide more analgesia. Pregabalin is absorbed throughout the small intestine, and so increasing doses are going to probably be more effective. The side effects are well known. Excuse me. Dizziness, and visual changes. Retinoids can block abnormal discharges, either from pain, spinal cord injury, nerve injury. So basically do is they're not working at the usual pain receptors, but they're altering the way the nervous impulses are coming into the spinal cord. Sensitization, and this is where if you injure a nerve, sometimes you get a feedback loop where it causes more and more pain, and so it can decrease that central sensitization and the development of chronic post-op pain. Pregabalin is good to post-op pain after a laparoscopic cholecystectomy. It can reduce post-op morphine consumption and reduce neuropathic pain when you look at it a month after total knee arthroplasty. Can be used alone. The results of studies show that the effect is mixed. So some patients get good relief, other patients don't get the relief you expect. In most studies, gabapentin does reduce narcotic requirements, but air doses do result in excess sedation, and so we just have to be aware of that, especially in the units after we care for our patients. So excess sedation in the PACU, excess sedation on the floor. Neuropathic pain is treated well with the gabapentinoids, and they're really best used in combination, again, with some of the other medications I've already talked about. So combine it with Tylenol, nonsteroidals, and now much opioid is used around the time of surgery. The pregabalin, Lyrica, is a real money maker. So, this is real money that the company makes, $4.4 billion. A couple of reasons. There's one here from December last year. When they randomized patients to receive gabapentin or to receive a placebo, what they found is that there was no difference in the time to provide pain cessation, but there were more patients who had resolution of their pain after surgery. So 24% more patients pain resolved after surgery compared to those who did not get gabapentin, and there were no significant side effects. So you may not see in the PACU or the first day after surgery the patients are using less opioid, but the patients are getting off their chronic pain medications faster. Hi, we use in the operating room, again, an old drug coming back very actively. This study, April of 2017, in the Anesthesiology Journal. Lidocaine acts by sodium channels, but the effect of the IV lidocaine has got to be more than just that simple chemistry. So the effect of lidocaine exceeds the duration of the infusion by more than 8.5 hours. So the drug is lasting, or the effects of the drug is lasting much longer than the drug presence in the blood. So again, if you in the operating room, stop it. The effects can last for many hours afterwards. So IV lidocaine does seem to have some effect on polymorphonuclear and so, again, some of its effect is felt not to be just at the sodium channel, but it has this systemic effect. I didn't want to know about all of this, but it just goes to show there's lots of newer studies to show that this the effects of IV lidocaine would be very helpful in the patients that we're taking care of. So lidocaine reduces intraoperative anesthetic requirements, reduce PACU fentanyl doses, and again, the long-term effect, it decreases postoperative opioid requirements and pain scores, both acutely on the time of surgery, but also chronically. So again, lidocaine is doing something to decrease the inflammatory response and to change receptors so that the patients are having less pain following surgery. Stop nausea and vomiting, faster return of bowel function, especially in our colorectal patients. The ability for patients to ambulate, and that can be just because they have less pain, but they're also less sedated from their opioids, so that they're up and moving faster. And then it improves the postoperative quality of life. And so this is becoming more important as people look at the medications we use and the techniques we use to treat pain, is how can we get the patients back to their operative quality of life. Intravenous IV lidocaine is not helpful for total hip arthroplasty for hysterectomy patients. I don't know, but it's pretty clear that IV lidocaine is helpful in breast surgery when those patients don't get another block. And remember, simple mastectomy, the top surgeries associated with chronic pain. So this would be a good time to use IV lidocaine. Spine surgeries, we commonly use that these days. Open abdominal surgeries, like a colorectal surgery where the patients don't get an epidural or a tap block, IV lidocaine would be a good choice. But it's also useful in laparoscopic abdominal cases when another block is not offered. And I do a list of surgeries at the bottom where it's not helpful to use IV lidocaine. Dexamethasone, a drug we use every day, lots of effects, inhibits COX-2 receptors, it's anti-inflammatory, and by itself it has analgesic effects. It's also a fabulous antiemetic, so it's a drug we should sprinkle on everybody as they come through the operating room. We do, I think. But here's a study that's now 6 years old where a single dose of dexamethasone decreased opioid consumption, improved PACU pain scores, and improved 24-hour pain scores. In this study, the doses they used were pretty big, probably bigger than what we commonly use, so 10 to 20 milligram doses, but they, again, got great analgesic effects. They showed that there was no increase in the risk of wound infection, which surgeons often worry about, or wound dehiscence. And it was unclear from this study about how the use of dexamethasone impacted glucose control. So we adjust how much dexamethasone we give to patients who have diabetes. Not conclusive, I think, yet for that. But in high-dose steroids, reduce the amount of pain in knee arthroplasty. And we should all know that the patients who are getting their lower extremity total joint replaced here at Methodist, at Lakeview and South Haven, are all getting dexamethasone in the operating room. Going on to Exparel. Exparel is a medication, liposomal bupivacaine. So you take a local anesthetic, bupivacaine, and you mix it in with some fat, and then the bupivacaine is released slowly, and so you can get a prolonged effect from the local anesthetic. It's that a lot of people want to use. The science for it is lagging behind, I guess I will say. It is currently indicated really only for tap blocks when we do abdominal surgery, and then it can be used for bunion surgery and oral surgery. So the science for those three uses is very good. For other uses, it's not as good as we might hope. Again, significantly more expensive than plain bupivacaine with the dose, the cost at the bottom. This is a Cochrane database review from August of 2016, looking at liposomal bupivacaine. In the paragraph at the bottom, right now the quality of the evidence is very low, and the problem is that the sample sizes that the papers have provided are very small. So you can show in a small group of patients that it might be helpful, but when you increase sample sizes, it's not as effective as you might think. We are using Exparel for a TAP box. Pharmacy has put some restrictions on its use for other indications. And if the price came down or the science it got better, then we might be using more of it. It's a wait and see kind of thing. I think with more evidence and with a better price, we could use it more. Some other medications that might be. We do see a number of patients almost every day taking or using medical marijuana. Remember that the cannabis plant has more than 60 different active molecules. Can provide analgesia and relaxation. And in that respect, it could be a good drug. Synthetic cannabinoids may reduce inflammation and the onset of neuropathic pain, but again, there's not a lot of science out there. So I think there's a lot of use, individual use, but the science, again, has not followed the drug. I think this is, as a parent, this is what I think is important, that use of marijuana lowers IQ, increased risk of respiratory diseases, increased psychotic disorders, and increased risk of substance abuse disorders. So again, right now, it's used every day, but it's not something that we're going to be using, I think, anytime soon. We use our mu receptor antagonists, and so there are also other opioid receptors, the receptor being the dominant. This slide, kappa receptors are anti-nociceptive. They help with pain, and they are anti-inflammatory. The problem is if they get across the blood-brain barrier, then they can cause dysphoria and hallucinations. So Cara Therapeutics is a company that has made CR845, which is a agonist that has potent analgesia and anti-inflammatory effects, and it does have a poor penetration of the blood-brain barrier, so it has little or CNS-mediated side effects. And I think that the drug is right now is in phase 3 FDA trials, and so this is something that we may see in the near future. Just a busy slide, but it did show that there was pain scores and less nausea and vomiting in patients who took this drug. So after that, how should we be treating pain now? So in pain, patients are still going to need narcotic pain medications. However, ignore our roles that what our previous practices were treating pain. We have to change those. So we have to optimize pain management using all these other analgesics and adjuvant medications, and then finally add opioids at the end. And again, we have to make sure that we're advocating for our patients, that using all these other medications before we start using opioids, and we're also giving patients and their families a way to get off of these medications as the pain gets better. In the old days, the finish line for those of us in the operating room was to get the patients to the PACU and get them out of the PACU quickly or get them home quickly. So that's the old finish line. It's now clear in 2018 that the finish line is getting our patients off opioid analgesics and returning them as quickly as possible to their quality of life. There's still remaining. Which medication should we use? How should we combine them? What gives us the best bang for our buck? Is it different depending on which surgery the patient has? We have to still do more work on looking at doses drugs. And then again, some medications we will use more for some surgeries. We still have to look into that. Doses depending on our population, especially with the increasing geriatric population, and then how long do we continue these medications post-operatively. Just so you all know, for the total joint replacement, the lower extremity total joint replacement patients, those patients go home with 3 weeks of Celebrex by the surgeon. So we are continuing on steroidals post-operatively. Question? For me?
How are these interact?
I guess what
Can we give for all?
Okay, it's a good question. So if the patients get Celebrex preoperatively, again, is mostly a COX-2 inhibitor. I think Twal is mostly a COX-1 inhibitor, and so I wouldn't advocate for its long-term combination, but I also don't think that it's bad to give a single dose of Toradol after they've gotten Celebrex. Yes.
Your research come across for like low dose.
So low dose ketamine can be used. There's some research showing it's used for 24 hours post-op. Is very effective, but I don't know how we would do that in a Bronson. So low dose chronic ketamine use does both decreases analgesic requirements, but also decreases, intermittently decreases depression in its patients. Rob?
Wondering if touch on it, opioid, but IV methadone,
You're right. So IV methadone, again, another old drug coming back. It's been around for a long time, but I think we're just starting to reuse it. IV methadone is a drug where you give a small amount to patients who are having either big surgeries or who are using pain medicines chronically. And again, the effect that it's providing is lasting longer than its half-life. So just a small dose of methadone, either in the pre-op area or in the operating room, will provide long-term, meaning days, effect for the patient, so lower opioid requirements after surgery, with very little respiratory depression. The one thing we do want to remember is if IV methadone has been used at the beginning of the surgery, is we don't want to be adding on long-chain opioids at the end. So if we're going to use opioids during the procedure, fentanyl is a better choice than morphine or Dilaudid. Probably isn't a pack. Anything else? Very good, buddy.